Hi everyone, it's my great pleasure to introduce my colleague and friend Rodrigo Ramalho from New Zealand.
Hi everyone, thank you Victor. My name, like Victor mentioned, is Rodrigo Ramalho. I'm a psychiatrist graduated from the University of Asunción in Paraguay, and I have a PhD in population health from the University of Auckland in New Zealand, where I am currently living. In this Science in a Nutshell video, I'll talk a little bit about a recent paper that we published, Telepsychiatry and Healthcare Access Inequities During the COVID-19 Pandemic, published in the Asian Journal of Psychiatry, which was the result of a joint effort from 17 psychiatrists from all around the world. I would like to acknowledge the early career psychiatrist section of the World Psychiatric Association for providing a network that allow us to get together during this time of crisis and join efforts, trying to contribute in whichever way we could. One thing we noticed as a group was a sudden need that most countries faced. Public health measures in most countries led to physical distancing, travel-related measures, the closing of some non-essential healthcare services, and even some inpatient units, all of which created a gap. People who needed care couldn't access it anymore, as they would have normally accessed it. It is in this scenario that telepsychiatry came to play a very important role. It allowed mental health care providers to provide care and support while at the same time maintaining physical distancing. We noticed that all our countries saw a sudden rise in the adoption of telepsychiatry, whether it was over the phone or via video conferencing, or mental health specialists providing support to colleagues working with people who needed mental health care, or providing support to healthcare workers themselves. Telepsychiatry was suddenly adopted en masse. Healthcare providers were open to this and people welcomed it. However, we also noticed that most of our countries were not entirely prepared to adopt telepsychiatry. Most of our countries, for example, didn't have local guidelines or appropriate training. Still, we were often, unfortunately, building the plane as we fly it. We also noticed other obstacles. Not everybody in our countries had access to the necessary technology, like internet, for example. Not everybody had the necessary digital literacy either, and other things like the impossibility in some countries to provide e-prescriptions that would allow people to access the medication they sometimes needed. All in all, it was unfortunately the case that often those who most needed access to telepsychiatry were those who were less likely to have access to it. That is, there were clear e-healthcare access inequities. Now, the thing is that we know some healthcare professionals and the population have come to notice the usefulness of telepsychiatry, and it is very likely that some professionals and mental health departments will continue to provide it after the pandemic. But one thing is also clear. We need to address these e-healthcare access inequities first. Otherwise, the use of telepsychiatry might end up contributing to inequities in health outcomes rather than contributing to diminishing them. In fact, addressing these inequities is not a task for the future, but instead is something we need to do now. We argue that it is indeed a long-pending debt with the population. Thank you for having watched the video. If you want to contact us, you can find our contact information on the article. And please remember to look after yourself and your community. And also that there is no health without mental health. Thank you.